Welcome to our webinar titled Decoding ADPKD, Diagnosis, Prognosis, and Genetics. This is the first of 4 webinars in our series that's titled Confidently Navigating ADPKD, Understanding the New KDIGO Guidelines. My name is Paul Scribner, Vice President of Community Programs and Education. I'll be moderating the presentation today. Now I'd like to say a thanks and acknowledge our sponsor, Natera. This webinar is supported by Natera by an educational grant, and the PKD Foundation has retained full control over the content and speaker selection to ensure unbiased, high-quality education for our community. Now to our speakers for today. So our first speaker is going to be Dwight Odland. He's going to share a little bit about his personal experiences with helping to develop the KDIGO guidelines, and he has been a PKD advocate since 2005, serving as the Los Angeles coordinator and a PKD Foundation board member and a contributor to the guidelines, the KDIGO guidelines, as I mentioned. He's also a living donor recipient. Our second speaker tonight is going to be Dr. Terry Watnick. She's going to talk about diagnosis and prognosis. She's an associate professor of medicine at the University of Maryland School of Medicine, specializing in inherited kidney diseases, and leads the Baltimore PKD Research and Clinical Core Center and the PKD Foundation Center of Excellence there in Baltimore. And finally, Dr. Neera Dal is going to talk about genetic testing. She's director of the PKD Foundation Center of Excellence at the Mayo Clinic in Rochester, an adjunct professor of medicine at Yale University, and an active clinical researcher in ADPKD. So now I will turn things over to Dwight Odland to say a few words to get us going.
Hey, thanks, Paul. Forgive my appearance. I just had cataract surgery this morning, but we'll move on. All right, so they thought I should give a little background about these KDIGO guidelines. And as Paul said, I was one of 2 patient advocates, along with about 20 world-leading researchers and physicians that put this together over the last 3.5 years. And we just all think it's an amazing resource, and therefore the foundation has started this webinar series to educate you all about it. So it was, the reason was to kind of standardize the diagnosis and care for the patients. It's a long document, but they've also put together 10 different one-pagers that I'll share with you in another future slide here to get your appetite whetted for the things that are in each one. And I would say it's a great reference for you. And it's also a great thing to use to talk to your doctors about to get better care. Next slide. So as I talked about, 3.5-year project, there was a great deal of work on evidence. There was the whole KDIGO staff went through thorough research about all the evidence out there that supports anything that we studied and then ultimately recommended or ended up suggesting future research projects for. And so the evidence is rated from strong to weak. And so everything here is evidence-based. An important part of this that became very obvious is that shared decision-making is embedded in this document. And I think you'll see it once you read it, that, everything is not going to come down from your nephrologist to you. Everything here should be a collaborative process where we all work together, right, to make our treatment decisions, incorporate the evidence, and then also consider your individual, your values and preferences, things that you're comfortable with too. So, and then technically, you go through, as I said, there's 10 different chapters. There's things like pain management, to aneurysms, to lifestyle things, and even mental health. It was very refreshing and gratifying, actually, to see these world-leading researchers and physicians respond and listen and pay attention and incorporate this the patient perspective. And Tess Harris from England and I, we were there not just to support our own stories, but to support the thousands of patients we've met over the last 20, probably 30 years in her case. So next slide. So this is my my slide to try to get you to read the paper. So there is a lot of stuff in here. There is a whole chapter on pain that includes pain, and there's a really it's a really good way to show the pain treatment options. It's an easy to follow format, and it starts out with the least invasive, and then of course it as things don't work for you, then you can consider moving up into more and more invasive things that will also impact your lifestyle. But it's it's one thing that's individualized for each of us, right? Uh, a chapter on dialysis and transplant, all the modes discussed, the outcomes, the patient preferences, more things that you can use to discuss with your family and also with your nephrologist when the time comes, if it comes. And then all about transplant, all about the reasons to have or to not have a nephrectomy, things like that. And then the one, of course, one of the areas we're most interested is patients, is what can we do ourselves? There's a whole chapter on diet, lifestyle, mental health. And so there's a lot here that we all can get a lot out of. So next slide. I think this is my last slide. So just to pitch this again, I think it's a great resource, not just for us, but for the nephrologists. And I've forwarded the guidelines to my nephrologist and my transplant center, and they've distributed them as well. And hopefully they'll get something out of it that improves care. As I mentioned before, we came up with a lot of areas where there's not sufficient evidence to make really solid recommendations, but we came up with a long list of recommendations for future research. And government entities, universities, and others use these lists because of the weight of this study, this paper, to prioritize future projects for PKD research. And then I mentioned the one-page summary. So if you can't get to it today, maybe Savannah could post this link in the chat, and you could take a look at it on your own. And in conclusion, I would just say, working on these guidelines was one of the great honors of my life, and I hope that all of you can get something out of it that helps your care. So I'm going to turn it over to my good friend Terry Watnick.
Hello, everyone, and welcome. Thank you for joining. I'm going to be talking today about decoding ADPKD. I'll cover diagnosis and prognosis. Yes, that's mine. Okay, so just by way of introduction, and I'm sure it doesn't need much, autosomal dominant polycystic kidney disease is the most common inherited form of kidney disease. And as you can see here, and I know there's no pointer, I don't think, but in the MRI picture over here, that it is characterized by multiple cysts in both kidneys that ultimately result in the kidneys getting quite large. ADPKD is the fourth most common cause of end-stage kidney disease worldwide, and Neera is going to talk about this more, but mutations in PKD1 or PKD2 account for most cases. Okay, so ADPKD is characterized by a progressive loss of kidney function. So in other words, as shown here in this diagram, when you're born, your kidneys may look normal, but over time, the kidneys develop more cysts, and these cause the kidney to get larger and larger. And this actually occurs over decades. So what you can see here is that the healthy kidney tissue declines over time, but the GFR, or the measure of kidney function, actually in the red line can remain quite sort of flat and stable even when the kidneys are enlarging and developing more cysts. And that's because the remaining kidney tissue can compensate up to a point. At some point, the kidney tissue can no longer compensate, and you can get a rapid decline in kidney function, as shown by that red line. What we have learned and what's clear is that most of the signs, or if not all of the signs and symptoms of PKD, which are listed over here on the right with these lines, are associated with growth of the kidney. So those include making more urine initially, with the urine being less concentrated, the development of high blood pressure, pain and discomfort and protein in the urine. All of this is really associated with enlargement of the kidneys. So enlargement of the kidneys is what is a manifestation of, it was what causes all of these manifestations listed below. Okay, so as I'm sure you're all aware, although me as a nephrologist, I deal mostly with the kidneys, ADPKD affects multiple organs in the body, and I've kind of shown that in the pictures here. So besides getting cysts in the kidney, cysts in the liver and pancreas are very common. And in the pictures over there, you can see on the right of the slide, you can see that the liver can become quite enlarged. This can lead to abdominal distension. And these cysts, especially in the kidney, can cause bleeding or they can become infected. In the kidney, at least, cysts can cause kidney stones. And most importantly, as shown in that picture in the middle there, you can have mechanical complications, just discomfort due to the combined size of kidney and liver. In addition to cysts, ADPKD is associated with brain aneurysms or cerebral aneurysms, shown in the picture at the very right on my screen with the arrow is an aneurysm. And these are among the most feared complications of PKD because aneurysms can rupture. Due to the size of the organs, hernias in the abdominal wall or the inguinal hernias, which are in the groin, are associated with PKD. Certain forms of heart disease are more common in PKD, and these include thickening of the heart wall, which is we call left ventricular hypertrophy or LVH. Some of that is related to chronic high blood pressure. Mitral valve prolapse is frequent in PKD, although it's frequent in the general population as well. And also other heart valves can be affected. As shown on the very right, ADPKD is associated with diverticuli or little outpouchings of the colon, and that's shown schematically here. You can see those little nubbins or little outpouching. They can become infected, and that can lead to diverticulitis. And then finally, male infertility has been described in ADPKD. And sometimes that is associated with seminal vesicle cysts or cysts along the male reproductive tract, although abnormalities in sperm have also been described. So the epidemiology of ADPKD, I told you it's the most common inherited form of kidney disease, and it's estimated to affect about 1 in 1,000. Some people think it's up to about 1 in 500 because some cases can be asymptomatic. About 10 to 25% of individuals do not have a family history, and that's for a variety of reasons. In some cases, people just don't know their family history, or people have passed away of other causes, or there is about a 5 to 10% risk of PKD mutations arising spontaneously. High blood pressure is probably the earliest and most common sign of PKD, and it affects about 70 to 80%, I'd say even more, of patients. We have come to appreciate that although overall about 50% of people who have ADPKD develop kidney failure in their in their early 60s, and that's overall, the disease is very, very variable. So there are individuals who develop end-stage kidney disease in their 70s and 80s or not at all. And then there are those people who develop kidney failure earlier, much earlier in life. So it is, as I'm going to touch on, important to determine the disease severity, and that's because it helps one to predict outcomes and also to inform treatment decisions. As I'm going to touch on again, and this is just an overview, how do we determine disease severity? A lot of research has gone into developing different algorithms for predicting. The one that we tend to use most often, or I use, is the Mayo Imaging classification, which relies on total kidney volume, which is height and age adjusted. And as I'll show you, I'm not going to go into too much detail here, but there are 5 different classes that we can use to predict disease progression. And then there are some people whose imaging just doesn't look like the classic form of PKD. In general, they tend to have mutations in other genes. and we have come to appreciate that they are at lower risk of disease progression. Okay, so I want to touch a little bit on diagnosis, and I want to focus here on those people who have a family history of ADPKD. So KDIGO recommends using ultrasound as the first step to determining if you have PKD. So you probably know this, but ultrasound uses sound waves to take pictures of your kidneys and check for cysts or the fluid-filled sacs. The diagnosis depends on how many cysts are seen and your age, and that's shown in this table here from the KDIGO guidelines. So I just want to point out that, even if you don't have PKD, as you age, and even you can develop some cysts in your kidney. So the question is, how do you distinguish that from people who have PKD? So there have been one very large study comparing ultrasound with genetics. So you could see cysts and you could verify whether a person really had PKD based on their genetics. And so that has led to this criteria for determining if you're at 50% risk, whether you have PKD. So between the ages of 15 and 40, if you have 3 cysts in your kidneys, whether it's in one kidney or in both kidneys, then that is consistent with a diagnosis of PKD. If you are between the ages of 40 and 59, it increases to 2 cysts per kidney. And if you're older than 60, it's greater than or equal to 4 cysts per kidney. And that is because if I took 160-year-olds out on the street, it would be very common to see a small number of cysts. So what this table also points out is that PKD2 is milder than PKD1. So, which means that these criteria are much, much better for PKD1 than for PKD2. And so you can see that here, that if you have PKD2 and you say that the criteria are greater than or equal to 3 cysts, there's going to be some percentage of people who will have a false negative test. They'll really have it, but they just haven't developed cysts yet. So that's an important takeaway from this. Most of the time, at least in the US, and this may be changing, we just don't know the gene type. And so in the very young people, these criteria, there can be some false negatives. And in my own clinic, I've had people come to me and say, I was told when I was 20, I didn't have PKD. And then later on, I developed cysts. So I just want to, again, emphasize that these guidelines are only used if you have a first-degree relative with PKD. So for example, a parent or a sibling. If there is no family history or if the results are uncertain, then you can always do additional testing, for example, MRI, CT, or genetic testing, which we'll touch on later. Okay, so why is making a diagnosis important? I should have said that before. It's because it helps you to get started if you make a diagnosis on monitoring your kidney health, managing blood pressure, and then addressing those symptoms before complications arise. In some situations, it may be necessary to exclude PKD, right? You want to make sure you don't have it. And I think the classic example of that is when someone who is at risk for PKD wants to donate a kidney to a relative. So again, either an ultrasound or MRI can be used to exclude PKD. And this table looks at the data for ultrasound where we really have, I think, the strongest data. So if between the ages of 15 and 40, if you have no cysts on your ultrasound, that is almost 100% predictive that you do not have PKD. I do want to point out, however, again, that because PKD2 is milder, the predictive value of a negative test is lower. It's only 84%, which means that you're going to have some small number of false negative tests. So if you're in a transplant situation and that's the case, you may need to go to gene testing. Okay, so again, if ultrasound is uncertain, you can also use MRI to exclude a diagnosis of PKD. MRI is much more sensitive, even in people without PKD. So if you do an MRI, you're just much more likely to see cysts which are benign. So in this case, for those individuals, actually, I think it goes up to 40, age 40. If you have less than 5 cysts, it has a 98% specificity for ruling out PKD. Okay, so let me move on. I wish I had a pointer. Okay, well, let me say, so whenever you're establishing a diagnosis, I think it's important, as Dwight mentioned, to engage in some kind of shared decision-making, and you want to consider what the implications are of making a diagnosis. So, for example, I think of the possible value of screening. First of all, people are anxious, so it may resolve diagnostic uncertainty, and it can provide reassurance if unaffected. It's the first step in managing and treating ADPKD, is knowing that you have it, and this includes screening for extrarenal manifestations like aneurysms. If you do establish a diagnosis, it allows one to participate in clinical trials. It may be important for some people for family planning, and I didn't list it here, but I think it is important also if someone wants to donate a kidney. There are also possible downsides. The psychological burden of knowing that you have a diagnosis when you may be entirely asymptomatic, especially if there is no treatment early in disease. There may be difficulty with employment or insurability, and we don't know what's going to happen on that front. And then there may be the cost of establishing a diagnosis, especially maybe in the case of genetic testing. So this wasn't the algorithm that KDIGO, I really like it. I want to say that they proposed for diagnosing ADPKD when you have a family history. Okay, and this is after you've embarked on that discussion and someone decides that they want to go ahead and establish the diagnosis. So the first branch point is if you know what your family's genetic mutation is. And in that case, you can go straight to genetic testing. Alternatively, if cost is an issue, you can just go down the pathway, have an ultrasound using the criteria, and the diagnosis may be either confirmed or ruled out. If it's equivocal, you can still always go to genetic testing. On the other branch of the test, if the family genetics are not known, so for example, you don't know what mutation your family has, you would do an ultrasound. You might meet those criteria that I discussed before, and then the diagnosis would be confirmed. Alternatively, if there are no cysts seen according to those data that I presented, the diagnosis would be ruled out. And of course, as always, there are just some cases where the findings are equivocal or it's atypical. And in that case, you can either consider going to an MRI to see if when you get a better picture of the kidneys, you have a better sense of it, or you can go to genetic testing. If you go to the genetic testing, you can confirm a PKD diagnosis. You may have a different form of PKD that's not PKD1 or PKD2, or as always, no matter how many rules we lay out there, there are always cases that we can't resolve. And in that situation, KDIGO recommends that you reevaluate the genetic test every couple of years because new data always is being accumulated, or to do follow-up imaging because if it is standard PKD, the number and the size of cysts will increase over time, and that may clarify a diagnosis. Okay, so what if there is no family history? In that case, here's the algorithm, which I also find useful. So first of all, always take a careful family history. And sometimes you will find out that yeah, there is a family history. If there are family members who have not been ultrasounded and if they will agree to be ultrasounded, sometimes you can establish that there is a family history, and then you would go to the first algorithm I presented. If that's impossible, I always recommend to physicians to look at the films themselves because sometimes it's just not typical for PKD. That can be either because there is a discrepancy between the size of the kidney and the kidney function. So I told you in PKD, as the kidneys get big, function declines. Sometimes the kidneys aren't that big, and yet you have the kidney function has declined. Sometimes the kidney, it just looks different. And in that case, you can consider an MRI to see if you can define it better, or you can always go straight to genetics, and that may help it, or as always, it may be equivocal, and then you have to continue to reevaluate the genetics and the imaging. Sometimes somebody will come to you, they don't have a family history, you look at the imaging, and it's very typical for PKD. In that case, you can establish a diagnosis, or you can also offer genetic testing to confirm that. Sometimes ADPKD, it's straightforward, it's diagnosed. Other times the genetics may be somewhat confusing, and then you have to continue to evaluate. Oftentimes, it doesn't happen infrequently, the imaging, you just see a few cysts. This happens a lot. I get consulted for people who want to donate, and they're incidentally found to have some kidney cysts. The function's normal, the size is normal, they don't have any aneurysms or liver cysts. And in that case, you can do genetic testing, or you can just continue to monitor. So then I just want to emphasize again, switching a little bit to prognosis, that although on average, I told you that patients with PKD or ADPKD develop kidney failure in their 50s and 60s, there is a really high degree of variability. And that's illustrated in this slide here. Both of these individuals are 43-year-old men, but one has a PKD1 mutation, the other a PKD2 mutation, and you can see that the person with the PKD1 mutation, their kidneys are much, much bigger and have many more cysts than the other person. So we have some understanding of the genetic factors, but we certainly don't fully understand everything that is responsible for this variability between people. So what we have come to do is that we have come to realize that kidney size, as shown here, really does help determine the risk of kidney failure, regardless of all of these other factors that we don't fully understand. And so the Mayo imaging classification is a way that we can use either MRI or CT scans of the kidney, also ultrasound, although it's not ideal, to predict how quickly PKD will progress. And the Mayo imaging classification relies on the total kidney volume, which means the overall size of the kidney, including the cysts, and we factor that by age and height. And so what is shown here is the basis for the Mayo imaging classification. So on the y-axis is the height adjusted total kidney volume, and that's just because people who are taller are allowed to have bigger kidneys, versus the age. And so all of these dots are one individual at one point in time, and then these were divided into 5 classes. And if you look at the A class, you can see that their kidney size really is predicted to increase more slowly over time as compared to class E. And so it makes sense. It makes sense that if you're younger and you have smaller kidneys, your prognosis will be better than if you're younger and you have very large kidneys. So that's what's shown here. What is shown here is that these different classes, it's not just the increase in size, but it also correlates with the loss of kidney function. So here, this E class, where the kidneys grow quite big, if you look at renal survival, you can see that that declines in that group much more quickly than those individuals in class 1A. So basically, the utility of this is it allows the clinician to get one imaging picture at a snapshot in time and use that to get a better idea of how your PKD will progress. So the Pro-PKD score is another way to estimate prognosis, and this is different in that it's based on a combination of genetic and clinical information. Sometimes in the States, in the US, we don't have genetic information, which is why the Mayo imaging classification can be so useful. And in the ProPKD algorithm, you give points for different clinical features. So that is shown here, the points. So because men tend to progress a little more quickly than women, if you're a male, you get 1 point. If you've developed high blood pressure before the age of 35, you get 2 points. If you've had one or more urologic event before the age of 35, you get 2 points. And then you get points depending on the type of mutation you have. So if you have a PKD2 mutation, you get no points. If you have a PKD1 truncating mutation that would predict the most severe outcome, you get 4 points. And then PKD1 non-truncating, which Neera will discuss, is somewhere in the middle, and you get 2 points. Okay, and what's shown here is the probability that your kidney function will survive based on years by the number of points you get. And these are kind of separated grossly into 3 groups. So over here are those people with the lowest number of points, 0 to 3, and you can see that they have the best kidney survival. Here are those individuals with 7 to 9 points, and their kidney function is predicted to decline the most rapidly, and then those in the middle, 4 to 6 points. So, oops, yeah. Okay, so I'm going to conclude this section of the talk. So essentially, diagnosis is made by imaging, but genetic testing can be helpful when the diagnosis is uncertain. Either height and age adjusted total kidney volume, which is the Mayo imaging classification that I reviewed, or the ProPKD score based on genetics can help determine the risk or the loss of kidney function. And then not everyone with kidney cysts has ADPKD or is at risk of losing kidney function, which is why it's so important to make a definitive diagnosis. And with that, I am going to turn it over to Neera.
Okay, I hope you can all hear me pretty well. So thank you for all joining. I think this is such a great audience, and I've been really enjoying seeing some of the questions as they come through, and then the PKD Foundation team answering those questions. So I think that's been just really fun to see that as the talk is going through. For those of you who had some questions about the genetics, hopefully it will become more clear as we go through this part. So the first part of this, it seems simple, but ADPKD, the first part is autosomal dominant, which means that the parent who passes on the gene for PKD to their child only needs to have one copy in which that variant causes disease. And so in this case, what I'm showing is that the father has PKD, he's affected, so he has one gene that you see the 2 alleles lined up next to each other. One has that yellow color on it, one has the blue color. So if the blue is the affected one, and he passes that on to, he has a 50% chance of passing that on to each child, then each child has a 50% chance of developing ADPKD. We think that in ADPKD, if you have the gene, particularly for PKD1 and PKD2, you will have disease. As Terry mentioned, PKD1 is the more common one. It causes about 78% of the cases, and PKD2 is the second most common and milder, causes about 15% of the cases. And this you saw really just highlighting the point that PKD1 is much more severe than PKD2. And we'll look at this in a little bit more detail. So because the genetics can have a really important prognostic implication, what KDIGO is recommending now is that when we say the person has ADPKD, we also list the gene name. So instead of just saying ADPKD, we would say ADPKD-PKD1 or ADPKD ADPKD2. And if you don't have genetic testing, that's okay. It's still called ADPKD. But if you've had genetic testing and we know what the variant is that's causing PKD, it gets this additional classification. And here is just a breakdown of those various different types of variants. So Terry mentioned that in PKD1, they're the truncating variants, which means that no full-length protein is formed, are more severe than the PKD non-truncating variants, in which a full-length protein is formed, but there's one amino acid change or one building block in that protein is different from what we think is the ideal protein structure for polycystin 1. So in this diagram, what I'm showing you is that PKD1 truncating mutations tend to be the most common. So of all people with PKD1 mutations, about 60% will have a truncating mutation, about 30% will have a non-truncating mutation. And then the next biggest column here are the PKD2 variants. And then what I'm starting to introduce in this slide is that there are other genes that now make up that PKD spectrum. And what are some of the indications for genetic testing? So prior to KDIGO, we said if someone had very early onset disease, we primarily think of ADPKD as a disease of adults, but there are times when children will be diagnosed with ADPKD, sometimes will be diagnosed within the first 1 or 2 years of life or in utero, and that those patients are considered to have very early onset disease, and so they would benefit from genetic testing. We talked about the young donor who might want to donate a kidney to a family member that has ADPKD. And so genetic testing for the family's variant that causes PKD may be helpful. It may be helpful in those patients who have no family history or an unclear family history for us to really make sure that that we know what gene is causing the PKD, or if there are some atypical features, so the imaging doesn't look quite like PKD, those folks may benefit from genetic evaluation. And KDIGO said, yes, we agree with all of those things, but we think that there may be an expanded indication for genetic testing. And some of that is if there's variable disease severity in a family. So we think that within most families that people roughly will develop kidney failure at around the same age, but if there's a wide discrepancy in that, that may be a reason to do genetic testing. If there's discordance, meaning if there's a difference between what we're seeing by kidney structure and then what we're seeing by loss of kidney function, that might be a reason to consider genetic testing. So it's really just saying that if you're uncertain, there may be more benefit of the genetic testing. And partly that reflects how far we've come with genetic testing. It's more common and more available, certainly, than it used to be even 5 years ago. And so I think we've really benefited from that. And then the PKD spectrum now composes 8 genes. So PKD1 is still sort of the biggest player, but then PKD2 we've talked a lot about. And the one I'm going to introduce next is called IFT140. And I'm introducing it in particular because we think that it's the 3rd most common of all of the PKD genes, but it has a very different prognosis than having either PKD1 or PKD2. Some of these other genes, ALG5 and ALG9, are associated with a pretty mild kidney phenotype, pretty mild kidney disease with very few cysts. And this gene, GANAB, can be associated either with liver cysts or with kidney cysts. And so it's sort of like sitting in the middle of causing either kidney or liver cysts. And this is a relatively new one, NEC8, which really presents in childhood and with fairly aggressive disease. All right, so some of the genes which cause ADPKD are rare, and many do not lead to significant loss of kidney function. So even though there are 8 genes in that PKD spectrum, some of them are associated with mild disease. I think the other thing, though, all of them may still be associated with liver cysts, with brain aneurysms, and with the other complications of ADPKD that Terry mentioned in really nice detail in the first part of this talk. So we think that all of these genes somehow affect polycystin 1 levels, and that leads to all of the complications we see with PKD. All right, and then the third most common is this IFT 140. And I'm just giving you a representative case here of someone that I saw. So a 70-year-old lady who has ADPKD. Her mother also had ADPKD, but never developed kidney failure. And at the age of 70, she has really well-preserved kidney function at about 50 mils per minute. With, if you don't know this term, the eGFR term, a normal eGFR for a healthy young 18-year-old would be 100%. We all lose a little bit of kidney function as we age, but we really worry about that rapid decline of kidney function that we can see with ADPKD. So a couple of things that make IFT 140 sort of a visual diagnosis is that you can see some of these cysts are really quite large, and they stick out of the surface of the kidney. And so when we see that, we think about this gene in particular, which is really associated with this really milder state of ADPKD. And this is just looking at now a total of 75 people who had this IFT 140 variant. And they tend to have what we call atypical classification. So the kidneys are not symmetric. They look very different from each other. Most had high blood pressure, about 50% had high blood pressure, but only 1 patient out of those 75 developed kidney failure. So it's a very different disease than ADPKD due to PKD1, for example. And then this is just showing you of some of the genes, what the percent is, population is, the likelihood of seeing it in the population. So PKD1, 78, PKD2, 15%, IFT 140, about 1 to 2%. And then there's one more word to introduce here, which is penetrance. So the likelihood that if you have a disease-causing gene, you're likely to have the disease is very, very high for PKD1 and PKD2. It's, in the 96 to 98%, which means that you could have the gene, you could be in that 2% that has the gene, but doesn't have clinically significant disease. Whereas with these other minor genes, the penetrance is less, meaning you could have the gene, but may not have any evidence of having disease. And then what KDIGO does nicely is they talk about these other genes that could look like ADPKD. And I won't go through all of them, but it's part of the reason that we're moving more towards genetic testing, because some of these genes are associated with very different outcomes and have different screening requirements. So COL4A1 can cause some eye problems, for example. And so you might be, they may say, hey, go get your eyes screened. It's a different kind of disease. These genes, PRKCSH, SEC63, and GANAB cause more liver cysts. And so again, the way we think about them is a little bit different. And I don't think it's important to know this list, just know that when we're looking at the genetic results, we're also thinking about, could any of these other genes be implicated if PKD1 or PKD2 is not implicated? And with that, I'm going to stop because I can see that there are lots and lots of questions. This is just a slide. My final slide is a picture we took at the end of our first annual PKD Center of Excellence meeting. And so we're really, really excited about this way of being able to interact. Basically, all of the providers taking care of PKD come together at least once a year to talk about strategies for care. Thank you very much.
Thank you, Dr. Dahl. These were great presentations, and we're going to jump into questions and answers. The first thing I'm going to do, though, is ask Dwight to come back on camera, because we have a question for him about his personal experiences with genetic testing, and wanted to give him an opportunity to just talk about those and any other perspectives he has that he thinks you all might find valuable. So I'm going to turn it over to you, Dwight.
Oh, hey, thanks, Paul. And I just answered a question online very similar to this, and it was from somebody who had genetic testing as a child. And so these are amazing technologies we have access to nowadays. And as Terry said, it used to be ultrasound, and now we have genetic testing to really prove if PKD is present. And so I just really wanted to share something that I found over 20 years of talking to parents and whether they should genetically or ultrasound test their children or not. And if you're thinking about doing that, all I would say is I would urge you to think about why. If the child is not exhibiting any symptoms, no blood pressure, or no any other issues that PKD is causing them, I've seen parents really just simply take out their anxieties and put that burden on their children to try to maybe bring them closer or to share their burden. And we all remember being children, right? And we're only a kid once, when all we care about is being safe and loved, and most of all, just being normal, right? And so that's all. I would just urge you to think about why you would want to get a diagnosis of someone in early childhood if there's nothing to be done. Do the things that you should be doing for any child, right? Raise them to eat well, take care of themselves, be fully hydrated. You can test their blood pressure occasionally. That's very important to see if there's any risk of PKD. So that's my little spiel. Thank you.
Thank you, Dwight. So I'm going to ask all of the speakers to come back on camera now. I'm actually going to stop sharing my screen here, and we're going to go ahead and jump into questions from all of you. So we've got a lot of questions that have been submitted, and we got about 15 minutes to get through as many as we can. So I'm going to start with the questions that have been upvoted by others of you, and we'll move through those. So the first question that I'm going to ask, and I'll pose this to you, Dr. Dahl and Dr. Watnick. Do these numbers or percentages that you've been talking about for disease severity for PKD1, PKD2, and some of the others, do they take into account now that people are taking tolvaptan? Or is that sort of just about the natural history of those diseases? And go ahead.
Sorry, I can start by answering that, and then Terry, please jump in. So what we were showing is really the natural history data. I think tolvaptan was really approved in 2018, and so we don't have a full understanding of how in the real life setting that's going to change the timing of onset of end-stage kidney disease. So that's a really important point, right? This is pre-tolvaptan, I would say, is looking at all of those numbers. Yeah.
Great. Anything else to add, Dr. Watnick?
No, I think it's the
right.
$1 million question. What's it going to look like?
Right. So the next question is from Lauren, and she just asked PKD1 versus PKD2. She didn't hear or understand how you know which one you have. And if you could just talk a little bit about that, that would be great.
Nira, you want me to take
Yeah,
a?
please. Yeah.
So, I mean, the only way you can really know for sure is doing genetic testing. But, there have been a lot of studies looking at family history, and family history can be somewhat predictive. So, for example, if you have people in your family that reached end-stage kidney disease after the age of 70, that would be highly predictive of PKD2, and if it's younger, highly predictive of PKD1. But it's a rough guide. And so, the only way to confirm it is by gene testing.
Got it.
You
Thank you.
feel free to.
Yeah, I agree with that. I think, sometimes the imaging for PKD1 and PKD2 looks very similar. It's a lot of cysts in the kidneys and some cysts in the liver. And so having the testing and having the family history can be helpful in differentiating those two.
Thank you. Sounds good. So the next question I'm going to ask is from Desh. And he talks about something called the HALT study, and I think you'll have to explain what that is. Study showed that maintaining lower blood pressure has a desirable effect on PKD, but he wasn't sure whether this was total kidney volume or GFR or both, and what was measured. So I wonder if you could talk about that briefly.
Mira, do you want to go ahead?
Yeah, so I think maybe we'll take turns. So HALT PKD was a study looking at 2 different blood pressure targets, and then looking at either combination therapy or single therapy for treating high blood pressure in PKD. And they didn't show a benefit in GFR, but they did show for those young patients that got randomized to the lower blood pressure group, that there was a benefit in total kidney volume. So it's the reason that for people who are at high risk for loss of kidney function in ADPKD, we target a lower blood pressure. We target a blood pressure of 110/75. For young patients under the age of 50 with good kidney function, that's our target. And it comes directly from that HALT PKD study, where we found that lower blood pressure improved total kidney volume, improved left ventricular hypertrophy, so the thickness of the left ventricle of the heart, which is the main sort of pumping part of the heart, and improved the amount of protein in the urine, which we also think is beneficial. So there were some benefits, but they're not the disappointment in that study was that we didn't also see a benefit in GFR, which we were hoping to see in kidney function.
Got it. Thank you. The next question is, I'm going to direct to you, Dr. Watnick. It's from Erica, and she just was confused, I think, about what you meant by an urological event when you were talking about diagnostics.
So the one that I think of the most is having blood in your urine.
Got it.
Okay, but most of those clinical events are really kind of directly related to kidney size. So, the bigger your kidney, the more cysts, the more likely you are to have a cyst rupture and have bleeding. But blood in the urine is the one that I think is the most common urologic event.
Got it. Got it. Thank you. And the next question I'm going to direct to you, Dr. Dahl. It is from Anonymous. So if someone is newly diagnosed with ADPKD in their 30s,
Yeah.
should they have an MRA test for aneurysms as soon as possible or wait for symptoms?
So the recommendations, we didn't get to it, but I'm sure it's coming up in the next webinar that we're doing based on the KDIGO guidelines. And that is how to manage the extrarenal manifestations, so liver cysts and intracranial aneurysms. The recommendation is if that person who was diagnosed in their 30s has a family history of ADPKD, and there are family members within their family who have developed aneurysms, then it's very clear that we would all recommend screening for that patient. Recommend screening whenever possible. It's not urgent, but definitely, once the diagnosis is made, if there's a family history of ADPKD and aneurysms, to get the screening done. I think if there's no family history, or the family history is equivocal for was there ADPKD and was there an aneurysm, then it's a discussion about when to have the screening done. And really, there's a lot of discussion in KDIGO about screening for aneurysms because on the one hand, the screening for aneurysms is expensive and most aneurysms are small and are only slowly growing. So you may find something that needs monitoring but doesn't need attention right away. And that's the reason not to screen everybody. But they're pretty clear that if people wish to get screening, if they're worried about having some symptoms, then it's reasonable to have that conversation and get screening if there's interest in
Got it.
screening.
Got it. And you actually answers a similar question from Glenda, who asked about, how often someone should get checked for cerebral aneurysm. So great. So the next question is, what has in your experience, what are the costs related to genetic testing? Is it covered by insurance? I guess this is for you, Dr. Watnick.
Yeah, so it's really variable. Oh, am I on?
Yeah, no, you're good.
You're fine.
Okay. Yeah, I think it's really variable and depends on the insurance. So clearly, if someone has PKD, like they have, everybody in their family has it, their clinical picture, I don't know if insurance will pay for it. I mean, but I think you try to make the case anyway that, if the diagnosis is in question. But at least, I mean, I don't know if we're allowed to talk about companies, but a lot of the companies have a ceiling of what your out-of-pocket costs would be if your insurance doesn't cover it. And it's far less than the actual cost of the test that they're asking insurance for. So, clearly for some people that's difficult and they won't be able to do it, but for some people it is. And I always, when I fill out those forms, I try to make sure that that nobody will get charged if they, can't afford it, so
Sure. Yeah, great.
kind of like order a test and then you find out they get it done and then they're out the money. That I try to avoid that. I will always warn people that this, depending on the service I'm using, this will be your maximum out-of-pocket cost if insurance doesn't cover it. And if, so it's decision making together in that case.
The next question I'm gonna ask is from Kay, and it's sort of in the same line, but it's about MRIs. And I'm sure a lot of other people are having the same question too. Were MRIs typically covered for PKD, for ADPKD?
I think it's really variable too. I haven't run into too many problems, but I think you may have to justify it.
Got it.
So far, I don't know, Neera, I have not had that many issues with it. Where I've had issues is with MRAs in people who are on Medicare. I have really run into a roadblock with that. But MRIs, I haven't had too much trouble, but I think you try to justify it. And if you can't, you could always do an ultrasound, even though probably it's a little bit less accurate.
Great. Thank you. The next question is from Trudy. And Trudy says, how long has the Mayo classification system been around and been available for use? And how long has the Pro-PKD system been around and available for clinicians? This is for Dr. Dahl.
Okay, so I think the Mayo, I didn't look at the actual dates, but it's been around for a while. It's not new information. So if I had to guess, I would say Mayo classification for at least the last 5 years, and the Pro-PKD score for the last 3, in that range. So they're well established. I think there are other groups beyond, from where the studies originally came from that have also shown similar things. So looking at PKD cohorts in different countries, they all show that like the Mayo imaging classification seems to stand up. in various different cohorts of patients. So it seems pretty robust. We are looking at whether there are ways to make that classification better. So whether there are different imaging biomarkers that may be more helpful than total kidney volume. So that's where the focus has been recently.
Got it. Thank you, Dr. Dahl. The next question is from Susan. And Susan says, do genetic testing reports state whether your mutation is truncating or mosaic? And you maybe want to explain what that means. This person is saying that her 2008 test does not mention these terms. I guess this is for Dr. Watnick.
Oh, I was going
You can pass it over, pass it along, please.
I will just say the ones that I get now, yes, they do. I think mosaicism is something that's very hard for companies like Natera to detect. I've only had it reported once. Usually it's a research lab that will detect mosaicism, and that is because they're looking at your blood, and that may not necessarily reflect what's in your kidney. You know what I mean? So mosaicism means that less than 50% of the genes have the mutation, and that can be hard to detect. But it should say the report whether it's truncating or non-truncating, and they may not use those words, but I think if you show it to someone who, you could, that they'll be able to tell you. And then now for sure, it would be pretty obvious in the reports we're getting now.
Got it. Thank you. Thank you. So the next question is from a woman that I believe that says her husband has ADPKD, but the hospital keeps rejecting genetic testings for referrals for their two kids. How do you suggest, if you have practical suggestions about how to get access to genetic testing, if that keeps happening? And I suspect others have maybe had similar kinds of experiences.
So I guess I would step back a little bit and just ask a couple of questions, maybe online for that person to think about. One is, Dwight spent some time talking about testing in kids. And I think unless there's a clear reason to test in kids, we don't typically use genetic testing as a screening tool, right? So we're not using it to try and determine whether the kids carry the disease or not. And if you have children under the age of 18, we say really monitor the blood pressure, all of those things with diet and lifestyle that are good for the people with PKD are good for kids. And so everyone in the family can be doing those things. But the reason to test would be if there's an indication of disease, right? So the child is complaining of flank pain or has high blood pressure or has some blood in the urine, then that would be a reason to do the testing. And still the first test would be an ultrasound and not genetic testing. So if the genetic testing has been done in the family, the child is likely to have, if they have the disease, is likely to have the same variant. So I would be very careful in trying to understand why the children are being tested. There are some ways that the testing can be done. So, and sometimes as a research study, that testing could be offered. But we're really cautious about testing in children because the testing has to change the child's outcome. Otherwise, the recommendation is to wait until the child is old enough to make that decision for his or herself about running the testing.
Got it. Got it. I'm going to ask a question that's just a tad bit off topic, but it's come up a couple of times here. Is there an age limit in which you can donate your kidneys for the donor themselves? It's a little bit of off topic, but there was a question about how old you can be to donate a kidney.
I'll take a stab at it, Nira, because there may be some differences depending on the center that you work at. At ours, I don't think there's a firm limit, but it's just an issue of as people age, they develop other medical problems that may preclude donation. I recently had a couple where they were both in their very early 80s and the husband donated to the wife because he was healthy and they had no reason to not do it. And it was a close relationship and there were, a lot of ethical discussions, but at the end of the day, it was determined that it could go ahead. So
Great. Okay, thank you. So this is going to be the last question, and then we're going to wrap up. If you, Dr. Watnick and Dr. Dahl, can actually talk about what genetic testing actually entails. What is the process like for somebody if they're going to do genetic testing for PKD, ADPKD?
Sure. So I'll start. So there are a few different ways. So the whole idea is to get cells with DNA, and then that DNA is extracted and it's run on a test. So one easy way is to give a blood sample, and that gives us a huge amount of DNA. So we like that test. It's usually very reliable in that we've gotten a complete sample. The other way is a cheek swab. So sometimes we'll mail kits to people to do at home. And it's just like sort of running the swab around the inside of the cheek to get enough cheek cells that you can then extract DNA from that. And then I think the hardest one to do is a saliva test, where basically in the saliva are all those cells that are in the mouth. And the hard part about doing the test is you have to fill the saliva vial up fairly full, and you can't drink water while you're doing that saliva thing. So you have to work really hard to get all of the saliva in that little sample tube. But either of those three ways are commercially available for doing genetic testing. And then the testing is sent off usually to a lab, and the lab extracts the DNA from that material and then assays the DNA. There are different types of tests involved, and so that's something that we as clinicians spend a lot of time thinking about. Are we just testing for the variant in the family? Are we testing for all of those different genes that can cause PKD? So sometimes the type of test we order is a little bit different. Terry pointed out that like testing for mosaicism, where one kidney may look very, very different than the other kidney, is extraordinarily hard. And so that might end up going to a research setting. And I think the one thing I wanted to say about the cost of genetic testing is I think we'll be moving within the next year or so into clinical trials that may be based on specific genetic diagnoses. And as that happens, there will probably be more availability for free or no cost genetic testing. That's part of the testing for them to see if they can find the patients that may benefit from drug. So I think all of these things will help make genetic testing more possible in the future.
Yeah, very, very clear and thorough answer. Thank you. Anything else you'd like to add, Dr. Watnick, before we wrap up?
no, but I agree
Okay.
that the
All right.
future, yeah.
Yep. And any final words you'd like to say, Dwight, before I wrap up?
No, it's been great. Thank you.
Yeah. So Dr. Dahl and Dr. Watnick and Dwight, thank you for your wonderful presentations. This was fantastic, and for answering all the questions. And on behalf of the PKD Foundation, I'd like to thank each of you for your participation in and the great questions you asked today. We had a lot of questions and a lot of participation, so thank you. And this concludes today's webinar. Thank you. Have a good evening.